So I'd like to introduce our 2023, a portion of our 2023 Resident Research Symposium. I've been asked graciously by Dr. Ellen Bogan to help direct and MC this event. So the way that this works is a somewhat rapid fire series of talks. I believe each presenter has about 9 minutes to present their work, a topic of their choice. I would ask that people please stay on time. And if anything, ending a little bit early would allow for a question or two from the audience, which I think will be helpful. Now, these are going to range from chief residents who are giving talks on some of their completed R25 work, and then all the way to interns who have not yet had a chance to establish a relationship with a faculty mentor. So please keep an open mind as well on the stage of the talk, and the interaction from the faculty I think will be really important. Dr. Ellen Bogan, anything to add before we get started?
Nothing to add, but thank you all for being here, and thank you, Mike, for hosting us. Thanks.
Sure. So first, I'd like to introduce Dr. Rajeev Sen. Dr. Sen is going to speak on the topic of dynamic prediction of patients at low risk for cerebral vasospasm in aneurysmal subarachnoid hemorrhage. So Dr. Sen, if you could take control of the screen and start.
Sure. Is that coming through okay?
Looks good.
Okay, great.
Yeah,
So
good.
morning, everyone. Thanks for the introduction, Dr. Levitt. Thanks for coordinating, Megan. So today I'm going to talk about a project that's been ongoing in our Cerebrovascular group for now a couple of years. And we're finally getting a little bit of traction, some preliminary data. So excited to share it with everyone and get some thoughts. As Dr. Levitt said, the title is Dynamic Prediction of Patients who are at Low Risk for Cerebral Vasospasm after Aneurysmal Subarachnoid Hemorrhage. The concept of predicting vasospasm in these patients is not something new. People have been doing it for decades, dating back to the Fisher score, which was our first early primitive model for predicting spasm, and we still use the Fisher score, modified Fisher score. So just shows that we haven't really changed much despite all these studies. And the bottom line is that none of these studies have created models that are sensitive enough or powerful enough to really impact in a large way, clinical outcome or decision making or making care more efficient. So I think that in large part, that's because what all of these studies do is they take a static number of data points on day of presentation, whether it's demographic, clinical, or lab values, and then try and predict an event that could occur, 3 days later or even 14 days after their presentation. Interestingly, there was a group that published in Stroke a couple of years ago, creating a dynamic model, so paralleling what we're trying to do. They trended vital signs over 14 days in the ICU. And I think they took hourly heart rates and blood pressures, and were able to do a pretty good job of predicting within 12 hours which patients would have an event of delayed cerebral ischemia or vasospasm. A couple issues with their study is that they achieved an area under the curve of 0.78, which is pretty good. But when we're talking about impacting how we take care of these patients and a complication like stroke and vasospasm, probably need to do better than that. And then they're using blood pressure parameters and heart rate and vital signs, which are easy and simple, but generic and non-specific, and probably limits to a certain extent, their predictive capacity. So our objective is to also use a longitudinal data set over 14 days, trending a variety of features, lab values, vital signs, and more importantly, supplement that with some radiographic features in the form of transcranial Dopplers. And again, we want to predict patients who are at low risk for vasospasm, who eventually we may be able to fast track or get out of the ICU. So here are our methods. In brief, basically, we're starting off with a retrospective study, looking at about 420 patients who were treated for aneurysmal subarachnoid hemorrhage at Harborview from 2014 to 2018. And we've collected about 177 features for each patient that's trended over 14 days. I've listed some of the parameters. We're looking at MAPs, CPPs, serum sodium, CSF studies, and then TCD values. So we're collecting all transcranial Doppler values, all velocities, Lindegaard ratios, pulsatility indices. And for outcomes, we're trying to predict two entities: clinical vasospasm, which we defined as patients who had some neurological decline and that resulted in further angiographic workup. And then patients who had angiographic vasospasm. So that would be patients who had angiographically confirmed vasospasm. All of our data is being worked on in collaboration with Dr. Lucy Wang, who's a associate professor in the Department of Computer Science, and she's helping us create a kind of a dynamic model to predict vasospasm or lack thereof. So jumping into some of our very early results, these graphs I'm going to show you are kind of big picture trends in our data. You'll notice there are no error bars. The point is not to find direct correlates, but really just to look at the global trends of a variety of features in our data set and kind of conduct a preliminary feature analysis. These bar charts here are basically looking at the distribution of patients who had vasospasm and those that did not amongst the various features. And I'll just point to a few notable trends. So here on the bottom left, looking at Hunt test score and Fisher score, you can see the dark bar is patients who had vasospasm, the light one is those who did not. As Hunt test score and as Fisher score go up, the proportion of patients with vasospasm goes up. So that's kind of validates what we would have assumed. And then same goes for GCS. As the patients who had lower GCS or were worse clinical state, they tended to have a higher proportion of patients who had concern for clinical vasospasm. Then looking more at the longitudinal trends, these line charts are basically trending certain parameters from, again, days 0 admission to day 14 in the ICU. The dark pink in these charts is patients who had vasospasm. Light pink are the ones who did not have vasospasm. And then I just pulled some notable trends here on the left, looking at MAP, mean arterial pressure, and then cerebral perfusion pressure in the top and the bottom. You can see that the pressures are similar, and then by about day 3, 4, 5, you see that the MAPs and the CPPs for the patients who went into spasm are consistently higher than the non-spasm group. And, that could be because they're autopressing or we're artificially augmenting their pressure. It's kind of hard to say from this data set, but it's kind of a notable and predictable trend. And then looking at the TCDs, some of the TCD values. So I've picked a few here, looking at the max velocity for AC on the left, MC in the middle, and then Lindegaard ratios. And again, these are trended. You can see that there's a pretty impressive difference in max velocity for the patients who went into spasm for both AC and MC, and that difference starts to taper off as towards the end of their ICU stay. What I did find interesting was that the Lindegaard ratios, that pattern is not as obvious. It's much more kind of erratic, and it's kind of surprising because we put a lot of weight on Lindegaard ratios, but this kind of shows you that the velocities are also very important, and important to the absolute numbers of their velocities are very valuable pieces of information. And I suspect that this study is going to reveal a lot more kind of interesting trends that we don't see in TCDs by the human eye, that we can maybe some delta values that would be important. So we've created some very basic models so far. These are static logistic regression models, so just data from a certain day and see how well it predicts patients who would not have vasospasm. So I'll just draw your attention to that red box below. These are to predict clinical vasospasm, and 0 are patients who did not have spasm, and their F1 score, which is basically like a area under the curve. 1 is a perfect model, is 0.67. So mediocre, but that's just taking static data from day 1. If you do the same for day 4, using the same parameters, again, looking at the box, you see that the model improves from 0.67 to 0.76. So just seeing an improvement as the days go on with even just taking static data points. And then just over to the right here, you can see that this is the plot looking at how different variables are weighted in the model. Top and bottom are the most weighted, either positively or negatively correlated. And you can see TCDs, and all the TCD values are all at the top. In the middle, you have things like BMI, CPB, things that seem to be less related. So in conclusion, the two main conclusions from these early kind of charts are, these graphs are, TCDs appear to be the most valuable features and heavily weighted, which is why we think it's imperative that they're included in any kind of predictive model for spasm. And then the predictive power increases as days progress. So that indicates that probably we're onto something by trending data as opposed to taking static day-by-day data. So next steps, we have a lot of plans for this project. Want to use our time series data to create a more complex model, apply it to hydrocephalus, eventually maybe be able to fast track people out of ICU based on this data. And then, of course, design prospective validating studies, looking at cost and multi-institutional studies as well. And a lot of people to thank for this project, led by Dr. Shaker and Dr. Levitt. And then, everyone else, including Dr. Wang, who's doing analysis, and Maggie McGrath has been a big help in this project as well. And she's going to present on it as well, I believe, next month. So I'll take any questions.
Great, thank you, Rajeev. Any questions?
Just quick comments on this. When we think about vasospasm, we always think about the correlation with the Fisher grade, and this is based on paper by C. Miller Fisher many years ago, where he actually classified the amount of bleeding and then correlated with vasospasm, and that's sort of what we've all used in the past. But it seems that there's a lot more nuance to it. Now, if we think about how we manage patients in our ICU, we are maximalist. We do everything. So we have nurses and residents and critical care staff and neurosurgeons examining the patients, usually at least twice a day. And then we have vital signs. We have transcranial Doppler being done by certified technicians every day. So we have a lot of information. But if you look at many places across the country, this is not uniformly so. And if you look at other places in the world, it's even less information as to how much and also how long the patients are kept in the ICU, et cetera. So the eventual goal of this project is to develop an app-based guidance system. So the app being something that'll go into the electronic record on a daily basis, and then provide guidance to the clinicians as to what complications can be expected. The main things here, of course, are vasospasm, hydrocephalus, but also keep in mind there are other problems like pneumonia, hyponatremia, et cetera. And then also perhaps provide guidance as needed about how best to manage the patient. So many steps to get there. And, Dr. Sen, Maggie McGrath, Shenoy Meyer, and in collaboration with Lucy Wang, they've done a remarkable job. This project's ongoing for about 3 years now. Initially supported by Microsoft, they dropped it. But the next steps are to validate this model using a prospective data set, and then create maybe a 3 or 4 institutional study in centers in the United States, and perhaps a few centers outside, such as Japan, India, Croatia, and China, and then see if we could provide uniform guidance to physicians about how to manage these patients, but also, how best to utilize resources. So a person with much lower prediction for spasm could be moved out of the ICU, whereas a person who are higher risk for spasm or other complications may need to be more vigilantly watched, et cetera.
Thanks, Dr. Shaker. We do need to stay on time here, and I see there's one more question, a question for the presenter by Dr. Chestnut. So I want to recognize that.
Yeah, hi, Rajeev. Just a question, since this is supposed to be a predictive model, how are you handling the interaction between it becoming clinically apparent or angiographically apparent that they already have vasospasm and the predictive data? In other words, predicting that someone's going to have vasospasm who already has clinical or angiographic vasospasm is less useful? How are you handling that?
Well, we have everything timestamped, so we're hoping that we can create a model that by trending data over the first several days can predict closer to the event rather than predicting the day of, but predict like that prior study did, predict, a day before, or really better risk stratify, as opposed to saying, hey, their risk is on day one, their Fisher score predicts their risk. Trending these data points, we'll be able to timestamp all that and then predict, we'll know when they had an event and then be able to predict, from a certain distance, how high their risk is. So the idea wouldn't be to, predict it on the day of, or, I don't know if that answers your question, but the idea would be to kind of risk stratify them more closely prior to any event.
Okay.
And thank you for the question and answer. And just a reminder that we really do need to stay on time. So we're going to start with Dr. Barros's presentation next about recruitment of collateral flow pathways during cerebral vasospasm, computational perspective.
Thanks. I'll get right into it. So as Dr. Levitt said, this is going to be a computational model looking at vasospasm, hot topic today. Before I get too deep into the talk, I just want to start out by thanking Angela Straccia. She's a PhD student finishing up her studies in Dr. Ali Sada's lab in the Department of Mechanical Engineering. And we published this study in the Journal of Biomechanical Engineering just this year. So I just want to really highlight all of her work for this. Is really her brainchild, and I'm just helping her out. So vasospasm is a common topic, and we know it well as neurosurgeons, especially at Harborview. It can result in delayed ischemic deficits in up to a third of patients with aneurysmal subarachnoid hemorrhage. And there's an imperfect correlation between radiographic vasospasm and actual ischemia, and then ultimately deficits as well. And this variation could be explained in part by recruitment of collateral blood flow. And this differs amongst patients with differing anatomy. And we see that frequently, that patients don't have complete Circle of Willis that we know from textbook. And the goal of the study is really to better characterize how the collateral blood flow occurs and how we might use it to help with vasospasm management. So to structure this talk, there's two conditions that we have for each patient. There's the baseline condition and the vasospasm condition. So from the CTA, patients all get CTAs on admission with aneurysmal subarachnoid hemorrhage. And we can use the CTA to create a 3D segmentation of the patient's inflow and outflow tracts. So ICAs, basilar, MCAs, A1s that we're all familiar with. And this creates a good patient-specific anatomic aspect to the model. And then in addition to that, we get TCDs on all these patients, as we all know. So this gives us all blood flow velocity data. And we can combine these two data points for each patient to create this CFD model and ultimately create a virtual angiogram. So not going to delve deep into the engineering and all the computational work that's outside the scope of this model, not enough time to talk about, but ultimately we create a similar scene to what we know with a normal clinical angiogram, and you can see the flow there going through the left ICA. So I'm going to show two patients that were included in this initial study. So patient one here with an intact Circle of Willis, there's a left ICA injection, AP view, and I want to just draw attention to that, the contrast going over to the contralateral side and also into the posterior circulation. So you can see there, right PCA and SCA are filling from this left ICA injection. So blood flow going both contralateral and also from anterior to posterior direction. This is just a diagram that we have here to better understand and display the direction of blood flow, which will change during vasospasm. And then the virtual angiogram corresponds very closely with that. Now in the vasospasm condition, I'm showing here basilar injection, lateral view from the clinical angiogram. And you can see there's blood flow going in the anterior direction, from posterior to anterior, through the PCOMs and into the right MCA even. You can see that there and the change in blood flow, or at least oscillating blood flow in that direction. And the thought behind this is that the basilar artery is in the vasospasm condition where there's severe vasospasm in the anterior circulation. the basilar artery is recruited to provide more inflow to provide the anterior circulation with better perfusion, and the PCOMs are recruited heavily. And you can see that there in the virtual angiogram, again, corresponds very closely with the angiogram that we see. Now, patient 2, to compare, has a right fetal PCOM. So this is, again, baseline condition, left ICA injection AP. And you can see, in contrast to the previous patient, there's no flow over to the right side. The A1 on the contralateral side is not visualized from this injection, and there's certainly no posterior circulation seen there. And again, just highlighting the right A1, and this corresponds well with the virtual angiogram. Now, in the vasospasm condition for this patient, all of a sudden we're seeing the right A1 filling. So the contralateral side is filling there, and the diagram shows that the thought behind this is that the left ICA now is getting recruited to fill the right side because of the severe vasospasm seen in the terminal right ICA. And you can imagine that we could use this data to help predict areas that could be at risk during vasospasm, ideally before it happens. We can use the CFD model to generate patient-specific virtual angiograms like the ones I'm showing here, and understand how blood flow could change in direction and magnitude in vasospasm, and try to correlate that with outcomes. One quantitative aspect to this model that could be really useful is quantifying vasospasm severity, as opposed to now how we subjectively interpret CTAs and angiograms and supplement that with TCD data. This could be a way to quantify that severity amongst vascular distributions within the model for that patient. So not to get too deep into physics, but we all remember V equals IR from high school, or should remember. You can think of voltage as the pressure drop and current as the flow rate. So resistance is related to the pressure drop and the flow rate. And you can think of it as how much upstream pressure is required to pump a given flow through a segment of the vessel. And this is influenced by the vessel diameter strongly. And we can compare that percent change between the baseline vasospasm conditions. And you can see that in the pressure contour there. So looking back at our patient 2 with the right fetal PCOM, they had severe angiographic vasospasm in the right terminal ICA, and the percent change in the resistance is significantly high in that area. And that could explain how the left ICA was recruited to cause more blood flow to fill the right side. So collateral pathways are recruited during vasospasm, and there's strong agreement between the clinical and the virtual angiograms seen in the study. And this differs between patients with different anatomic variations, as we saw between our 2 patients. And this provides a quantitative method for us to compare vasospasm severity within the patient from the baseline and then in vasospasm. And we could see how routine CTA and TCD data could provide input for generating real-time patient-specific models to identify the high-risk patients and high-risk areas for that patient for delayed cerebral ischemia. And right now we're expanding this cohort to 28 patients. And I think with enough patients modeled and different variants seen in baseline and vasospasm, we could generate a nice tool for us to use in the future in the clinical setting. So I just want to thank everybody again, highlighting Angela Stracher. This is again her brainchild, and I'm just helping. So Dr. Bass as well, our own Dr. Levitt, Dr. Allenbogen, and Dr. Ali Seda from mechanical engineering. Thank you.
Great, thanks, Gil. And I'd like to open it for 1 to 2 questions as we try and stay on time. I'll start with one then briefly. Just, one of the problems with computational fluid dynamics is its clinical applicability, and we have been unable to bridge that gap in many ways. So how do you see this as being a clinical tool? Is it more of an adjunct? Is it more of a population-based predictive tool? How do you see this getting in the hands of physicians who can actually use it to impact patient care?
Yeah, I think we would have to, of course, streamline it to be automatic. I think if on admission with the CTA and the initial TCD data, we could, generate these virtual angiograms to help us understand how, like a software, basis, we could modify to see, okay, if there's change in flow if there's spasm in this area, what could happen with the change in flow direction. I think that could help us understand, what areas could be at risk.
Great. And, I think the plug for this is just that, it's simple to say, oh, there's spasm or there isn't in a binary way, but the elegance of this approach is that it is actually very difficult to quantify clinically, but it is a relatively straightforward engineering problem because it's just pipes with different resistance. So thank you for that, Guil. And now we're going to move on to Dr. Mike Meyer, who's going to present CTA versus angio for diagnosis of penetrating cerebrovascular injury. Dr. Meyer.
Okay, so Mike Meyer, I'm one of the R7 chief residents. I'm going to present some data that we've collected over the last 3 years that shows that a digital subtraction angiogram is superior to CT angiogram to diagnose penetrating cerebrovascular injuries. In the interest of time, I'm going to summarize the background by saying that there are some retrospective series that suggest that CT angiogram is pretty insensitive. But they're retrospective only. The only prospective study comparing CT angiogram and catheter angiogram for penetrating cerebrovascular injury was limited to stab wounds, which also found that CT angiogram was unacceptably insensitive, but it was limited to a mechanism that's much more rare in the civilian penetrating head injury population. So this is a multi-center prospective observational cohort study of patients with penetrating head injury of any mechanism to determine how often cerebrovascular injuries happen in a civilian penetrating head injury population, and to determine how sensitive CT angiogram is compared to a digital subtraction angiogram. I'm only presenting Harborview data today. We have another center, the University of Utah, that has between 15 and 20 patients that we'll be including in the study as well, but they haven't completed their data collection yet. So inclusion criteria was all patients with penetrating brain injury of any mechanism. Exclusion criteria was any patient with an unsalvageable devastating neurologic injury, which was decided by the neurosurgeon rounding on the patient, or any patient whose family decided to withdraw care, and of course anyone who didn't agree to participate in an angiogram. For the purposes of this study, we use the same definition that the previously published series used, which is any penetrating cerebrovascular injury is any intracranial pseudoaneurysm, any dural arteriovenous fistula, cavernous carotid fistula, dural venous sinus thrombus, or dissection or occlusion of any major intracranial artery. The definition of major intracranial artery are listed below. In summary, it's any of the proximal arteries or of the anterior circulation, or the named arteries of the posterior circulation. So we have 52 patients in our series from May of 2020 to March of 2023. The age range from 9 to 72, about 3/4 of them were male, and we present with all range of GCS. Majority, 45 out of 52, were gunshot wounds to the head with 7 low velocity stabbing type mechanisms. Penetrating cerebrovascular injury is very common. 42% of patients had at least one injury. Many of them had more than one. The sensitivity of CT angiogram in this population in our series was 41%, with a 95% confidence interval of between 20.7 and 63.7% using the Klopper-Pearson exact method for confidence interval for a percentile. So at best, less than 70% sensitive, which is the highest that was reported in a previous retrospective series. It's reasonably specific, about 83% with a confidence interval of 65 to 94%. So total cerebrovascular injuries that we saw, there are more than 22 here because many patients had more than one. Dural venous sinus thrombosis was common. Pseudoaneurysms were common. Major arterial occlusions and dural arteriovenous fistula also. And then we saw several cavernous carotid fistula, which were always associated with an internal carotid artery pseudoaneurysm, and major arterial dissections as well. CT angiogram misses certain categories of this very frequently. So CT angiogram never misses a dural venous sinus thrombosis. It misses 5 out of 7 pseudoaneurysms, including several that required treatment. two major arterial occlusions, every dural arteriovenous fistula and every carotid cavernous fistula that occurred, and one major arterial dissection in the petrous segment of the internal carotid artery. So in conclusion, I think that CT angiogram is inadequate for diagnosis of penetrating cerebrovascular injury due to how insensitive it is, and that a catheter angiogram is necessary. Likely of any mechanism, but certainly for gunshot wounds to the head. More research is needed to ascertain the best timing. There is some controversy on whether this should be done up front. In our study, the majority received their angiogram within 48 hours. Some other centers believe it should be done somewhat delayed to catch pseudoaneurysms that may be thrombosed. This study is not designed to capture that, and I think we need to do a follow-on one to examine that further. And then also, we just need a larger population so that we can study this in mechanisms other than gunshot wound. Because while this study appears to be sufficiently powered to prove this conclusion for gunshot wounds to the head, stab injuries are so much more rare that it would take probably 3 to 6 times as long to collect those patients. So this is a list of everyone that has helped along the way since I came up with this idea, either by advising me or by performing the angiograms or helping with the data collection. Dr. Grandi is our partner from the University of Utah. He emailed me last week that he should have his data to us by next week. So I think we'll be able to publish this in the next month or two. And with that, I'll take any questions.
Great job, Dr. Meyer, and really thought-provoking, considering, I think most importantly, the lesions that were actionable lesions, treatable or needed treatment or change management that were missed by CTA. That's a really strong conclusion. Do we have any questions from the audience?
Just want to commend Mike on a good study that's changed the way we take care of these patients at Harborview. While we're getting angiograms as part of the study, I think we'll be going forward doing it on everybody. So it's been really powerful.
I think this is a good example of starting with a clinical question and then realizing that there's a gap in the literature and just thinking thoughtfully about how to fill it. And I think we're all surprised at just how high impact this could be. Thank you, Dr. Meyer. And I think with that, let's move on to our next talk. Our next talk is Dr. Adriel Barrios-Anderson, one of our superstar newest residents, who will be speaking to us today on locoregional CAR T cells for children with CNS tumors, clinical procedure, and catheter safety. Take it away, Adriel.
Hi, Dr. Lovett. Thank you very much, everyone. My name is Adriel. I'm one of the interns. Thank you for the introduction. And I am going to be speaking a little bit about locoregional CAR T cell therapy and the specific approach developed that's novel for delivery of CAR T cells at Seattle Children's. First, to give a bit of background on CAR T cell therapy and the rationale for using it in pediatric CNS tumors, and then I'll move on to discussing locoregional delivery and the rationale for that, followed by describing our specific method that was developed at Children's, the delivery, some of the preliminary demographics and safety data, and then discuss briefly the future directions of this type of work. As you all know, pediatric CNS tumors represent or make up the most common childhood solid cancer, making up about 1 to 5 cases per 100,000 children. And while surgical approaches and adjuvant therapy have been particularly useful in improving the 5-year survival rates of medulloblastoma and low-grade gliomas, poor prognosis still remains for a host of pediatric CNS tumors, including diffuse intrinsic pontine gliomas, as well as high-grade midline gliomas. And that's where researchers are still actively engaged in thinking about immunotherapy as well as other approaches for targeting these CNS tumors. In particular, CAR T cell therapy or chimeric antigen receptor T cell therapy is being considered because of its preliminary utility as an approach in hematologic malignancies in the pediatric population. Very briefly, this therapy is an approach in which antigen receptors are developed
that essentially hijack the immune system's natural response to target tumors or malignant cells, and use it as a way to specifically target malignancies of interest. In this case, the goal would be to do this to target CNS malignancies in the pediatric population. The specific challenges for using CAR T-cell therapy in pediatric CNS tumors in particular are twofold. First, most CAR T-cell therapy that's been used, as I mentioned, has been shown to be effective in hematologic malignancies, and that is done by a systemic CAR T-cell infusion. However, the rationale for, if we are really trying to treat pediatric CNS tumors, the benefit of CAR T-cell therapy is thought to be greater if we can enhance the on-tumor, on-target efficiency, meaning the amount of literal CAR T-cells that can be that can target the malignancy of interest, which makes systemic CAR T-cell therapy not ideal if we're trying to access the CNS, in part because of the blood-brain barrier, which is our second challenge, which would, creates a high degree of, it influences the ability for us to use systemic CAR T-cell therapy because the penetrance of a systemic approach associated with systemic CAR T-cell therapy would require significantly higher doses. And CAR T-cell therapy has been associated with toxicity, in particular CNS toxicity in the non-CNS malignancy population, things like seizures as well as worsening edema in the central nervous system that have been associated with CAR T-cell therapy. So one, reducing that dose that's required to bypass the blood-brain barrier, or bypassing the blood-brain barrier more directly could be of value. And further, in a population that is already at risk for neurologic injury or neurologic adverse effects, such as seizure, a therapeutic approach that increases that risk is not ideal. So a potential solution, and what has been used is in a number of clinical trials that are taking place at Seattle Children's, is this locoregional intraventricular approach to delivery of CAR T-cell therapy. So this locoregional delivery, as mentioned, is being done in a number of clinical trials. There are 3 brainchild clinical trials that are targeting HER2, EGFR, and B7H3 targets for a host of CNS malignancies in the pediatric population. And I'm going to talk now about the focus of this work, which is the specific method developed for delivery of CAR T-cell therapy using Ommaya or VP shunts that's been done at Children's. So as you know already, Ommaya reservoirs have been used in the adult population for some time for the delivery of locoregional chemotherapies as well as immunotherapies in the CNS. The other approach that is being used is one of hijacking or borrowing the VP shunt delivery system. A lot of the patient population that presents with pediatric CNS tumors already have VP shunts in place for obstructive hydrocephalus. And so by using that shunt as a method for this locoregional delivery, the team at Children's has been able to use both approaches for delivery of CAR T-cell therapy quite effectively. The method involves, for the Ommaya reservoir, involves a direct delivery system with very little complication. And so it has not required necessarily pre-evaluation by our neurosurgical team. The VP shunt delivery system, however, has, and the specific approach that we use at Children's has been first to do a shunt series followed by a CT scan to assess the patency of the shunt, the type of shunt being used, as well as to verify that there is no risk of mechanical obstruction or other issues with the shunt catheter prior to using it for therapy. The approach is quite straightforward once all of this preparatory work is done. The site is cleaned and prepped, site and position is verified first with an injection of preservative-free normal saline of about 1 cc, and then CSF aspiration with a butterfly needle, followed by a CAR T preparation that's infused for approximately 1 minute and a saline flush to flush the rest of the therapy out of the CAR T preparation, out of the distal tubing. The proximal tubing into the system. Preliminarily, this work has been done, like, as mentioned, in 3 trials with an N of 41 individuals. About 307 intra-Ommaya and VP shunt CAR treatments have been done successfully. And one of the significant benefits of this approach is that this is done primarily in the outpatient setting. So it provides a way for this treatment to be done in the outpatient setting, which is much more tolerable for the pediatric population and seems to be working quite well. The few patients that have had inpatient treatment, it has been coincidental, given that they needed inpatient treatment for, they required inpatient treatment for another reason, but not for the CAR T cell administration. Most of the patients in the population have been male, and a number of pediatric CNS tumors, including diffuse intrinsic pontine gliomas, as well as embryonal tumors, ependymomas, and high-grade gliomas have been a part of these trials in total. Of importance, the safety of this is one of the biggest components of this method that it is most powerful. There have been 0 serious adverse events in the host of these treatments at Children's. There was 1 instance of skin breakdown for a VP shunt that was placed at a prior institution, and that was replaced without issue. There have been no allergic reactions, 0 instances of CAR T infusion cancellation due to mechanical obstruction or other issues, and 0 instances of infection, including meningitis or skin site infections such as cellulitis, which is always a question and has been a question in the adult population as well, with Ommaya reservoirs being used as a method for treatment. That said, this data is consistent with prior data that has demonstrated that both VP shunt and Ommaya reservoirs being used as a mechanism for delivery of chemotherapy or immunotherapy on a regular basis into the CNS does not carry with it a significantly higher risk of infection when compared to things like a PIC, for instance. So future directions of this work are very exciting, and preliminary work from one of the participants of the HER2 trial at Children's demonstrated that first, there was a local inflammatory response that we can see here immediately post-infusion of vasogenic edema seen on neuroimaging, and then correlated effectively with CSF, cytokine and chemokine levels going up, as well as systemic serum inflammatory responses going up as measured by CRP. The preliminary work demonstrates first that there is a change that is happening when this delivery of CAR T cells is done. And then this local inflammatory response is something that is expected. And the question that really remains is if this is the kind of response that we want that can be of value in long-term treatment, which is the biggest question that remains, is the question of efficacy. Does this treatment pose a possible option for this patient population, or is there a pediatric subset of pediatric CNS tumors that respond to CAR T cell therapy? This remains to be seen and is really the goal of the trials in the long run. Another question is, if there is such a subset, does local regional dosing or even anatomic positioning of the delivered therapy matter at all? There are preclinical studies being done to assess whether the placement of the Ommaya reservoir or the specific location and neuroanatomic location of the delivery of the therapy plays any role. All of these things still remain, but the exciting work that is continuing to be done at Children's is something that I think can be of tremendous value for a patient population for which we still do not have effective treatment. I'd like to thank everyone in the Seattle Children's Brainchild team, including Dr. Vitanza and the Vitanza Lab, as well as Dr. Hauptman and the neurosurgical team at Children's for their support and teaching about this exciting work.
Nice work,
Thank you.
Adriel.
Nice work. Yeah, sorry, excuse me, Dr. Allen-Logan. Any questions from the group about this work as we move on to get the next participant ready?
Adriel, very
Mike,
nice work. Sorry, go on.
Please, Ali, go ahead, please.
Okay, thanks. Quick question. I couldn't remember whether you talked about the timeline of follow-up on these patients. My question is more focused on, whether with especially what you show on imaging, is there any concerns for shunt or catheter failure with these immune cells being injected through the catheter and potentially colonizing the tips of the catheter?
Yeah, that's a great question. I didn't mention timeline. That hasn't been seen yet. And I think that I don't remember exactly what the timeline is at this point in terms of the longest follow-up for someone who's been getting CAR T cell therapy is at this point. But that we haven't seen that yet. The other thing that I was thinking about and that's of note is that only about very, very small amount of the infusion is actually, volume-wise is used through this approach. So from a just layman's physics perspective, I'm not sure. But I think that's an important question that kind of longer follow-up would need to answer.
Great, thank you, Dr. Barrios-Anderson, for a great presentation. I'd like to move to our next talk, Dr. David Bass, who will be discussing his presentation, modeling the effect of coil packing density on the mechanical microenvironment of coiled aneurysm. Dr. Bass.
All right, thank you. So as Dr. Levin mentioned, I'll be discussing a follow-up study to the project I've presented over the last couple of years on my R25 work, in which we used Lagrangian particle tracking to study blood flow through coiled cerebral aneurysms. But with this project in particular, we'll be using that same tool to try to identify an optimal coil packing density. So we know that coil embolization has decreased morbidity and mortality associated with treating aneurysms relative to open clip ligation, but this has come at a cost of about 10 to 30% risk of recurrence. And therefore, understanding why these aneurysms recur and how we could prevent that is of utmost importance. In the study of recurrence, packing density is a clinical metric that has garnered significant attention. It's easily calculated by taking the volume of the coil that's deployed inside the aneurysm dome and dividing that by the volume of the actual aneurysm itself. And a number of studies have shown that decreasing packing density is associated with increased risk of recurrence. However, there have been some conflicting findings in the literature. What we do know is that successful occlusion depends upon stable thrombus formation, and that thrombogenesis relies on outlier or extreme events to trigger the clotting cascade. Indeed, our previous work using Lagrangian particle tracking showed that clot formation was likely triggered via low shear stress pathway. And the way we studied that was by taking 3D reconstructions of patients' aneurysms and obtaining patient-specific boundary conditions and plugging these data into a fluid simulation software in which we were able to perform our Lagrangian particle tracking, in which we tracked the trajectories of tens of thousands of inertialess particles throughout the model. These particles can represent any small blood-borne components, whether they be platelets or even proteins dissolved within the blood, such as fibrinogen. But the important point to take is that they are a tool that allows us to calculate the coordinates of particles, their trajectories, and the shear forces they experience along their pathway through the model. And then we can take this data and analyze it, focusing our analyses specifically on the outlier extreme events, which we defined as the 99th percentile. And we focus on several key metrics that can be obtained. The first of which is residence time, which is the amount of time that particles spend within the aneurysm dome. We know that stagnant blood flow increases residence time, and that stagnant blood flow forms clots. So increase in residence time is thought to reflect a prothrombotic environment. And indeed, in our first study, we saw that the post-treatment condition had a significant increase in residence time compared to the pre-treatment condition. We also looked at shear history, which is the accumulation of shear stress acquired while the particle is in the aneurysm dome. This is a well-known biologically important mechanism. It's been platelets that are exposed to high shear stress, for example, will degranulate, and that's the initial step in forming clots. Interestingly, in our study, we saw that the post-treatment condition had a significant reduction in shear history. So we were able to, one of the next steps that we did was combining these two metrics together in a simple ratio of shear history to residence time, which gives us an average rate of accumulation of shear stress while the particles are in the aneurysm dome. And we saw that this metric was also significantly reduced in compared to the pre-treatment baseline. So this is the results of the study are painting a picture in which treatment or coil embolization specifically increases residence time and reduces shear stress. Overall, promoting an environment that would facilitate polymerization of fibrinogen into fibrin. And this conclusion is actually supported by post-mortem case series in a number of small studies. But these findings also led us to our next question, which is whether or not those metrics can be used to identify an optimal coil packing density. So to answer this question, we selected a subset of subjects from the prior study and then reran their simulations at varying packing densities relative to the actual treatment packing density, so ranging from 50 to 200%. And the first metric we looked at was particle entry, and this is essentially blood flow into the aneurysm dome. On this scale, 0 represents no change from baseline, so the post-treatment condition would be the same amount of flow in as in the pre-treatment condition. And then negative 100% represents complete occlusion. And what we saw was a nearly perfect correlation between increasing packing density and increasing occlusion or obstruction of flow into the aneurysm dome. We also noticed that we achieved nearly 80% of this effect by the time the aneurysm was packed 1/3 full with our coils. So looking at our metrics of residence time and shear history below this 1/3 packing density threshold, we see that there's a proportional increase in residence time associated with packing density. And we also saw that there was a negative correlation with between shear history and packing density, and a negative correlation between that shear history to residence time ratio in packing density. It's worth pointing out that both shear history and this ratio have a maximal effect of 0. So there's a ceiling effect or floor effect that can be achieved hemodynamically with these metrics. And looking particularly at the trend line for the rate of accumulation of shear stress, we see that it's approaching 0 near this 1/3 packing density threshold. So this may reflect a point at which the optimal packing density or point of maximal hemodynamic effect can be achieved at this 1/3 threshold. However, when we look above that threshold, we see that particles end up getting stuck within the aneurysm dome throughout the duration of the simulation. And while they're there, they're actually accumulating massive amounts of shear history at a much higher rate than below that threshold. So the point our study is at now is trying to determine whether or not these particles represent, or these data points represent, a true hemodynamic effect, or if they're simply an artifact due to the limitations in the model that we're using. But regardless of the answer to that question, we're seeing that increasing packing density has a predictable effect on some very biologically relevant metrics. And there's reason to believe that the maximal hemodynamic effects you can achieve through coil packing may be achieved near this threshold of 1/3 packing, of a 1/3 packing density. Long-term looking, our goal here is to be able to develop pre-treatment simulations that can guide the clinician towards an optimal packing density, and perhaps even redirect them towards alternate treatment strategies, or supplementing packing with stent-assisted coiling. So with that, I just want to thank a large number of people, particularly Dr. Ellenbogen, Dr. Ogeman, who's the PI for the R25 grant back when I received it. Of course, my close mentors, Dr. Kim and Dr. Levitt, And then Dr. Alice Sada's lab in the mechanical engineering department has been phenomenally helpful. In Laurel Marsh, I came up with a whole workflow pipeline that I just took essentially on block and applied to a slightly different clinical question than she'd been using. So with that, questions?
Questions from the group? So I can pop in since this is obviously something I'm deeply involved in, and I do want to commend Dr. Bass for maintaining the research momentum after his R25 year, continuing to ask questions as they come up from the previous publications and showing a sustained involvement in his scientific pursuits. I think that's going to serve him well as he graduates our program and moves on to becoming a physician scientist. So, you know, the question here again is just how do you think this is going to affect people who are actually treating these aneurysms? I know you mentioned it briefly. Can you just talk about why packing density as a variable just isn't good enough? Why are we not just using that? And what's a typical packing density for an aneurysm treatment, just for those who may not know in the audience?
Yeah, so certainly very good questions. And part of the reason we weren't able to answer this question with the previous study is because the packing density for most of our treated aneurysms is around 20%, which doesn't give us a lot of variability when we're trying to map out this parametric space. But as you can see in this slide, even in our models across the spectrum of packing density, there's still quite a bit of variability that's not fully encapsulated or explained by the packing density. You can see some of the correlations here are, even though they're significant, they're still quite low. So this is one important metric that needs to be incorporated into the patient-specific aneurysms. And we expect certain metrics or morphologies of these aneurysms play a key role. So finding a way to work those in should help explain some of this variation in the data that we can't capture or fully explain with packing density.
So I think, yeah, so I think the opportunity here is that packing density by itself is probably a contributor, but not a clear and obvious predictor of treatment outcome. And so the interaction between packing density and some measure of the hemodynamic environment, so how the blood is behaving and if and when it starts to form a stable thrombus, is probably going to demonstrate some augmented accuracy predictive model over just packing density or hemodynamics alone. Any other questions? All right.
Thanks again,
Thank
Dr.
you.
Clark.
Yep. Thanks, Dr. Bass. So our next speaker for this morning is Dr. Scott Boop. Dr. Boop will be discussing his project, Reducing Early BP Shunt Failure with Perioperative Selective COX-2 Inhibitor Administration. So take it away, Dr. Boop.
All right. Thank you, Dr. Levitt. Can everyone hear me and see my screen okay?
Yes.
Yes.
Great. So thank you for the opportunity to speak today. For those of you who don't know me, I'm Scott Boop. I'm one of the fourth-year neurosurgery residents. I'll be discussing my upcoming research year project, which is involved in reducing early BP shunt failure in pediatric shunt patients with selective COX-2 inhibitor administration peri and postoperatively. I'd like to go ahead and upfront thank my research mentor for this project, who's Dr. Hauptman. So just as a little bit of background, I think we're all very familiar with hydrocephalus, but for those who don't know, hydrocephalus is a disorder characterized by aberration in CSF or cerebrospinal fluid production, absorption, or flow throughout the central nervous system. There are multiple etiologies that contribute to the disorder, making treatment as a whole, as a single disorder, difficult due to variability in the cause. The main two causes of hydrocephalus really broadly are sort of obstructive reasons from things such as tumors or congenital abnormalities that cause narrowing in the CSF flow pathways, as well as communicating hydrocephalus, where there's no obstruction, but there's an issue with absorption or production, and that can be related to infection or leptomeningeal disease or various other etiologies as well too. Globally, pediatric hydrocephalus is a huge deal. It affects about 88 per 100,000 children globally. The cost alone in the US exceeds $2 billion annually. Part of that is due to the cost for revision surgery for shunt procedures, which are the mainstay of treatment for hydrocephalus, with the average cost for revision admission being well over 53,000, average length of stay 3 days or more. And this is sort of a cumulative burden because shunt failure is not a one-time thing. It's often a thing that patients repeatedly experience. And then hydrocephalus in general is the most common condition requiring neurosurgical intervention in children, both in the US and globally. And so the opportunity to reduce shunt failure and reduce that burden would be a boon for neurosurgical care in general, as well as cost effectiveness. So the mainstay of treatment of hydrocephalus is the VP or ventriculoperitoneal shunt, which takes a catheter, places it in the brain, tunnels that under the skin to an area elsewhere in the body where cerebrospinal fluid can be absorbed. And this reduces the ventricular caliber and pressure within the intracranial space. The primary modality is the ventriculoperitoneal shunt, so that distal tubing is plopped into the peritoneal cavity where it can be reabsorbed. And this technology has really been sort of unchanged grossly since the 1950s when it was invented. There's been modest improvements in shunt design, including antibiotic impregnated materials, a host of programmable valves, some of which I have demonstrated here, as well as anti-siphon devices. But even with a large variety of research and development into improving shunt design, failure rates remain high, with about 50% of these systems failing within the first 2 years, about 30-40% within the first year. And it's estimated that there's about 2 to 4 needed shunt operations within the first 2 years following initial placement of one of these devices. There's been a large amount of study looking at ways we can reduce the shunt failure rates, including all those shunt designs, the changes that I just mentioned. And it's been thought for a long time that proximal catheter occlusion is primarily related to choroid plexus infiltration and obstruction of these proximal ventricular catheters. And that's related to studies that have shown that proximal occlusion accounts for over half of all failures within the first year. As well as sort of grossly what is seen in the operating room when some of these catheters were explanted. But explantation studies, as well as studies showing techniques to cauterize the choroid plexus at the time of implantation, have not really borne this theory out. And more recent research highlights the role of neuroinflammatory cells within the CNS, namely microglia and astrocytes in shunt obstruction. So microglia release an inflammatory milieu of prostaglandins, cytokines, and reactive oxygen species in response to local tissue injury in the brain. And in particular, the prostaglandin pathway is critical for propagating the inflammatory response. And that is primarily mediated by cyclooxygenase 2, which has been shown to have increase in expression quickly following traumatic brain injury or any sort of local tissue injury. And those concentrations are driven up precipitously. Eventually, this leads to inflammatory cascades that stimulate microglia, and that activation eventually leads to reactive astrocytosis. And so previously, our own Dr. Hannock in 2016 studied the contents of explanted catheters with 3D confocal microscopy and showed that initially showed that overall microglia and astrocytes are able to bind to the catheter contents of these shunt catheters, whereas choroid plexus really wasn't, but could adhere to the scaffolding caused by these microglia and astrocytes. And then the dominant type of cell type sort of depends on the duration of the implanted catheters. So microglia predominant cells or predominant scaffolding is seen in the first 2 months following implantation of the catheters. And then over the next couple months, that slowly changes to an astrocyte dominant picture. So the hypothesis of this study is that using pharmacologic methods to reduce the neuroinflammatory response to these shunt catheters will reduce the rates of shunt failure within the first year following implantation, as it may reduce that CNS response, cellular activation, and scaffolding that may be causing some of these proximal obstructions. The only FDA-approved COX-2 specific inhibitor is celecoxib or Celebrex, which fortunately has a safe side effect profile similar to ibuprofen, crosses the blood-brain barrier, and does not increase the risk of bleeding or impair platelet function, making it an ideal medication for this study. So the study aims are twofold. First, we'll conduct a double-blind, placebo-controlled randomized clinical trial to assess whether celecoxib can reduce early VP shunt failure rates within the first year, and then also to assess whether including this medication in the peri and post-operative regimen will result in improved functional recovery for pediatric patients because it is overall anti-inflammatory and pain medication. So this is a consort diagram for our study. Like I mentioned, it's a single institution, placebo-controlled randomized controlled trial taking place at Seattle Children's. And our plan is to administer 6 milligrams per kilogram of celecoxib or a placebo immediately perioperatively and then postoperatively for 24 weeks with overall 1 year of follow-up. We anticipate needing to assess around 360 patients for eligibility. Our inclusion criteria are patients older, 2 years or older, who are either undergoing initial shunt placement or revision, and those with external ventricular drains that are being converted to VP shunts. And the reason for the age is because celecoxib is not FDA approved for children less than 2 years of age. So our exclusion criteria are those less than 2 years old, those with ventricular atrial or ventricular pleural shunts, cardiac comorbidities, renal disease, GI ulcers or liver disease, patients with known coagulopathy or on anticoagulation, those taking medications that may alter the metabolism of celecoxib, so CYP, 2C9 alterating medications, those with NSAID or sulfa allergies, those who are pregnant, and those with a history of poor medication compliance. Postoperatively and functional recovery or post-op pain and functional recovery metrics will also be collected for secondary analysis, and our outcomes are shunt survival at 6 months and 1 year, and then the functional recovery with post-op pain scores and number of days until return to school or normal activity if patients are not in school. So there are some pitfalls that we're going to have to deal with as part of this study, namely recruitment and retention. Fortunately, there's a very robust shunt infrastructure already in place at Seattle Children's in terms of a registry already in place, as well as substantial follow-up infrastructure, making the loss to follow-up for these patients very minimal. Another is medication placebo tolerance. So we're going to work closely with the Seattle Children's Investigational Drug Service to develop an appropriate placebo and establish a data safety monitoring board that will periodically review patient risk and medication tolerance. And then another issue is potential confounding variables. There are 6 pediatric neurosurgeons on staff at Seattle Children's, so there, will be naturally some variability between surgeons, as well as shunt types. As I mentioned, there's a variety that can be used, but we will attempt to match across the cohorts whenever possible. And I think overall these issues will be small because shunt procedures at Seattle Children's are so protocolized that there's very little variability between surgeons, and most, if not all, the surgeons basically use the same shunt type as well. So with that, I'd like to thank Dr. Jason Houtman, as well as Dr. David Bass for a lot of the legwork on this study that he performed previously, as well as Dr. Durfee and Dr. Christine McDonald for their support in developing this project, as well as Dr. Ellen Bogan for his mentorship as well. And with that, I'll take any questions.
Yeah, Scott, thank you. I have a question about powering that study because, as you said, 50% are proximal obstructions, but what percent of those proximal obstructions are choroid plexus and mechanical obstruction brain versus inflammatory? In order to power up that study, you're going to have to probably screen more than 300. I'm just asking.
It's certainly possible that we'll need to screen more than 300. I think overall the average for shunt placement or revision at Seattle Children's is about 30 per month.
No, I know that, but what percent of them are inflammatory versus proximal obstruction mechanically?
I see. I don't have the specific numbers on what might be mechanical obstructions. I can say the majority of the shunt failures that we see and take care of here are proximal obstructions by far. I don't think we have specific numbers on if that's mechanically related to some other issue other than obstruction of the catheter, or specifically what specific cell types are obstructing the catheter in those cases. But that's something that we may try to look into.
Well, Scott, you might want to look. There's a paper by Dr. Laligam Shaker from, I think it's about 30 years ago, that looks at this and, sort of the I'll call it the myth of mechanical obstruction. Because I think the reality is you don't know. That's the point.
Right.
But it's really it's a great example of there's no new ideas under the sun.
Remind me.
It's a fun read.
Yeah. So yeah,
Oh,
boss. If I can just jump in for a sec. I think that it's a good question, boss. I think the evidence suggests that things that we've been assuming are mechanical obstruction or choroid plexus obstruction for many years might not be, and it might actually all be a result of the inflammatory cascade. And what we think is choroid ingrowth is really essentially proteinaceous debris that bridges to the choroid. That's a result of the inflammation that exists once you place the catheter. So I think that's going to be really part of the question. I think a lot of the work that Sam and Brian Hannock did, which really laid the foundation for the science here, suggests that I think what we've been calling mechanical obstruction might not actually be mechanical obstruction, and it might be cellular ingrowth, from the inflammation.
Well, that's wishful thinking. I hope we have a medical cure for this. I really enjoyed that talk.
Yeah, me too. And I just had one question. So anytime that you're working with something like as complex and specific as a randomized placebo-controlled trial, the trial design is as or more important than the trial execution. And the biggest problem you have is, or the biggest problem you might have is that you might have a great idea and it might be completely biologically sound, but if the trial is designed not poorly, but improperly, or you might lose the signal for the noise. So I missed it, but what was the power calculation that you thought you needed for capturing the primary outcome measure of shunt failure reduction in patients with COX-2 inhibitors?
Yeah, thank you. I'd have to go back and look at our specific calculations again, but it was I can get that to you separately, Dr. Levitt.
Yeah, I mean, this is a huge question.
It's powered to design a 25% difference. That was a magnitude of effect that we thought would be clinically meaningful. And that's based on changes in shunt survival. This addition of the second aim is to maximize the chance of a positive study. I think your point is 100% accurate, Mike, that when you design a clinical trial, you do have to be really, really thoughtful about trial design. The addition of the second aim, which will end up being secondary objectives and endpoints, is to maximize the likelihood of finding something positive. I think it's almost certain that we're going to find enhanced recovery with the addition of the COX-2 inhibitor, even though that's not the primary objective and endpoint. But I think that's what's going to probably save this trial if the biological foundation doesn't result in a clinically meaningful change. But to answer your question about the power calculations based on looking at changes in shunt survival, based on historical data of 6-month shunt failure.
Yeah, so I think that's reasonable. I think, the key here is just estimating the effect size of the intervention is going to be critical, and you may not have much to go on, but if you have even in vitro data or animal data that suggests that there is some percentage reduction in inflammation or some change in the rate of growth of the inflammatory cascade or something, that will help. And then the other thing I would encourage you to do is think about whether there are any non-invasive biomarkers, imaging biomarkers that could hone your recruitments, to Dr. Ellenbogen's point, that you could preferentially choose patients who are at higher risk of some kind of inflammatory process to mediate their shunt failure. Because I agree, it would be great if they were all inflammatory, but that is in some ways significant wishful thinking. And so I think it is something to consider that, you're talking about randomizing 182 patients, but are they the right 182 patients? And if you have a type 2 error and you miss because you're recruiting patients from the wrong population, obviously you're limiting your generalizability a little bit, but I think if there's anything you can do to focus down on higher pre-intervention likelihood patient population, you're going to be probably pretty happier. Also, just remembering that the rate of failure is not 75%. The rate of failure is 25 to 40%. So you're going to get down to smaller and smaller numbers of these patients. So the primary outcome measure is going to be a relatively low hit event compared between the two. And so the fragility of your study is going to be somewhat elevated.
Yeah,
I think it's fascinating and I love it. And I'm very hopeful for you guys. That's why I'm like trying to understand the specifics.
Yeah, and the best part of this, it'll be down to a single surgeon. Dr. Hauptman's going to do all the shutters for the next 5 years. So thank you, Jason, for that.
That's great. And thank you for the great discussion. I just want to keep us on time here because I've been talking too much too, and sorry about that. But let's move on to our next talk, which is Dr. Maddie Greil, who's going to talk about expansile duraplasty following traumatic spinal cord injury. And I don't mean to cut the discussion short, just want to make sure that everybody has a chance to present.
Thank you, Dr. Levitt. So I'll be talking about some work that I started with Dr. Seigel when he was still here, looking at expansile duraplasty in acute traumatic spinal cord injury. As a bit of a background, as you all know, traumatic spinal cord injury can lead to debilitating motor weakness. And similar to the much more studied traumatic brain injuries, secondary injuries can occur due to mechanisms such as edema, ischemia, and inflammation. So again, similar to in TBI, some of the potential targets for trying to get people better eventual motor outcomes are things like early surgical decompression and optimizing spinal cord perfusion. A bunch of different medications have been tried for these, and there have been other kind of surgical trials. But one of the thoughts is that by expanding the intradural space, can we decompress more thoroughly, and can we increase spinal cord perfusion after these injuries? So the objective of this study was to assess whether expansile duraplasty is associated with greater motor recovery in patients with an acute traumatic spinal cord injury compared to bony decompression alone. So this was a retrospective study. The patient population was adult patients who had an acute traumatic spinal cord injury who came into Harborview Medical Center, and patients who underwent a surgical decompression and stabilization procedure, either with an attending in the neurosurgery department or orthopedic surgery. We based our study population off of the trauma registry for this. And then we only included patients who discharged from the acute hospital to inpatient rehab. We collected patients from February of 2017 to June of 2021. The kind of control group for our study are patients who underwent decompression and fusion procedures alone. And then our study population was patients who underwent decompression and fusion, and at that same time underwent an expansile duraplasty. Our primary outcome was change in motor score, and the secondary outcome was complication rates, to make sure that this additional portion of the procedure wasn't putting patients at higher risk. So for the expansile duraplasty itself, the decompression and fusion procedure were performed according to however the attending surgeon typically does this. And then after hardware replacement and laminectomies, we performed a 3.5 centimeter dural opening and then put in a suturable patch, which was sutured to the surrounding dura, as seen in these diagrams. So a linear opening of the dura and then sewing in the patch to expand the intrathecal space. All of these surgeries were done by Dr. Seigel. As far as patient demographics for both groups, the average age was around 50 years. there was no significant difference between the two groups as far as their ASA scores, level of injury. Preoperative motor scores were a little bit higher in the non-Duraplasty patients than in the Duraplasty patients. And again, we only had 11 patients who underwent Expansile Duraplasty, but the other significant difference in these patients was the amount of time that they were both in the hospital and in rehab, which was statistically different between the two groups, with the Expansile Duraplasty patients spending longer in the hospital and then also longer in rehab. It's a little bit hard to say exactly why that is, but my suspicion is that it has to do with the lower baseline motor scores of the Duraplasty patients, the fact that they needed a little bit more time for recovery. As far as complication rates, the overall complication rates between the two groups was not statistically significant. No patients in the Duraplasty group had to return to the operating room for a wound issue, and about 6% in the non-Duraplasty group returned to the operating room for a wound issue. No patients who had CSF sent during their hospital stay had positive cultures in either group. And then we also looked at other things like DVTs, PEs, urinary tract infections, and pneumonias, and found no significant differences between the groups. As far as case duration, that was longer in the patients who underwent Duraplasty. But the thing that we were looking at for our primary outcome was the motor scores for patients, and then also the change in motor score from preoperative baseline to both hospital discharge and rehab stay. We didn't find any significant difference between the motor scores themselves at hospital discharge or at rehab discharge. Again, keeping in mind that the Duraplasty patients started with lower motor scores than the non-Duraplasty patients. At the time of hospital discharge, the change in motor score from preoperative baseline to hospital discharge was trending in the direction of being higher for Duraplasty patients, but not statistically significant. But at the time of discharge from inpatient rehab, there was a significant difference in the change in motor scores from preoperative baseline to the point of rehab discharge, with about an 11-point change for the non-Duraplasty patients and a 20-point change for Duraplasty patients. So we did find, some indication that Expansile Duraplasty patients could have a greater motor improvement at the point of rehab discharge compared to non-Duraplasty patients. As far as complications, there were no significant differences, and we didn't have returns to the OR, which would be one of the kind of more likely things that we were worried about, with opening the dura when it wasn't previously opened, kind of the risk of CSF leak or infection. That wasn't the case, at least for these 11 patients who underwent this. I think this is obviously a very preliminary study with a small number of patients, but I think that if this, could help patients, it was definitely something to continue to study in a prospective, more controlled manner in a multi-center study. I just wanted to thank my co-authors, obviously Dr. Seigel, and then Emily Robinson, who is a medical student here, and Dr. Torres Espin, who helped us with statistics at UCSF, and then the Department of Neurological Surgery, who has supported me through all of my research endeavors. And then we'll take any questions.
Hi, Maddie. Thanks for presenting those data. It's really, it's great. A couple of things here right now is, we have continued that work, and we're collecting, a biomarker right now to sort of see what patients indeed have something. Again, we call it a compartment syndrome, when the spinal cord reaches the dura and is effaced or compressed by the dura. And so far in our cohort, intraoperatively, we really have not identified any patients where that's the case. The first question is, how many of these patients have had lumbar drains?
A few of the patients did have lumbar drains. It wasn't all of them. I don't have the number off the top of my head, though, but that's a good question.
Yeah, so I think that might be one little, bias there. And the second thing is that the interesting finding that we have right now, and we'll have actually putting a paper on this together right now, is that in animals, the subarachnoid space in the around the spine is like 2 to 3% of the entire circumference. In humans, it's 25%, so the subarachnoid space is much larger. So it seems to be less of an issue, only in some patients, and we don't know who those are yet. So part of my DoD grant that I just got is going to be a 3-day follow-up MRI, so we can see what patients have patent subarachnoid space versus none. So we can really identify patients that might theoretically benefit from something like that. So that's just where this type of research is right now.
Great, thank you.
Can we just briefly ask, Dr. Chestnut has his hand raised. Dr. Chestnut.
Yeah, just a couple of complicating issues in the selection of patients. An uncontrolled variable is the choice of patients to undergo decompression. The other is the mixture of surgeons in the non-decompressed group versus single surgeon in the decompressed group. And finally, there's a subtle selection in choosing just patients that went to rehab. Those are all going to be difficult to account for and all going to be quick reviewer questions when this is submitted. Have you thought about just comparing or doing sort of case matching? Or you don't have a huge patient population, but case matching for severity at least in comparing the two patient groups when you look at the amount of recovery, because the amount of recovery available is obviously greater in a lower Asia patient.
Definitely, those are all good criticisms of the study. I think, we're severely limited by the number of patients, and obviously that only one attending surgeon was doing this. So they're all kind of things that we're thinking about and seeing if there's a better way that we can analyze the data. I think, as far as patient selection, while Dr. Seigel was taking spine trauma call here, he, for that window of time, was doing it in all patients that he was taking to the operating room with a spinal cord injury and decompressing. So looking back at those, there weren't patients that he was specifically selecting to do this in versus not, but it definitely does have an impact that he was the only one doing it compared to all of the other neurosurgery and orthopedic spine surgeons.
Great. Sorry to cut short the discussion there. It's obviously a topic of significant interest, and again, something that could be it's reasonably easily testable, and we see enough of these patients that something to study further. I'd like to introduce our next on a related note.
And again, Mike, that's exactly what our follow-up study is doing. So we're actually looking, first of all, to Randy's point, we have an intraoperative biomarker now to select patients. And again, so far, really have not been able to positively identify these patients that really predictably benefit, like you mentioned before from the shunt study, identify a patient population that could reasonably benefit from this. I think that's going to be the holy grail. And so in the DoD study, we're going to get a three-day MRI to sort of see who swells up, who is going to develop a compartment syndrome and who not. So to address that, exactly that.
Great. So let's move on to Dr. Sanan Sivakanthan, ultrasound in human spinal cord injury and update. Dr. Sivakanthan, please take it away.
Hey, good morning, everyone. For those of you who don't know me, I'm one of the R6s. I'll be presenting my work on ultrasound and spinal cord injury, presenting the translation from bench work to the operating room. This is a continuation of the work that I started in my R25 year. I was recently presented and awarded at the AANS spine section. By way of background, ultrasound works by producing sound waves that are emitted from the transducer and then reflected by an object. They're reflected back at different times, which results in different resolution of different tissues. In Dr. Hofstadter and Dr. King's lab, we use microbubbles, which is a form of ultrasound contrast that's made up of a lipid shell as well as a carbon core. That has a specific harmonic signal, and the use of these microbubbles allows us to visualize perfusion in vivo, allowing for quantification of spinal cord perfusion. So over the next few minutes, I'll explain my research, bringing the injury model from the lab all the way to the human spinal cord. We'll work through how the injury model proves hypoperfusion and how that hypoperfusion affects function, and finally how that function can be translated into the operating room. So to begin, what you're looking at here are on the left contrast enhanced spinal cord images, and on the right susceptibility images of rat spinal cord after impact injury. This is a fairly simple concept, but it's a kind of an important foundation, and that is that with progressively increasing injury severity, you get a progressively increasing area of perfusion deficit, as well as increased deflection of the microvessels of the spinal cord. Not only did we look at this from kind of a gross anatomical perspective, but we also used fluorophores and histopathology to very painstakingly count all of the perfused vessels within the spinal cord after the injury. What we found was that at the lesion center, virtually all of the vessels had lost perfusion, whereas even just 2 millimeters rostral caudal to that injury center, we saw maintenance of perfusion based on fluorophores. So bringing the next question becomes, how does hypoperfusion of the spinal cord affect functional outcome? And in rats, we use something called the BBB score. This graph is a little bit busy, but what you can see is that with increasing perfusion, with increasing injury severity, you get an increasing perfusion deficit and progressively worsening BBB score. Ultimately, this proved to be statistically significant, and we demonstrated that perfusion is a biomarker to predict functional outcome in rats. So my job was to bring all of this into the operating room, and what we developed was a spinal cord injury, a spine perfusion index. What this is basically during the time of surgery, we administer contrast after decompression and image the spinal cord after in the operating room. From that image, we can calculate the relative perfusion of the injury center compared to a cranial and caudal control area. How this works is that the contrast inflow is measured over time by the ultrasound. What we can do is kind of paint a region of interest at the injury center and areas above and below the injury center. And by taking the area under the curve, we can calculate a perfusion index by comparing those two areas under the curve. The other thing we looked at was what we called the spared tissue, which was the dorsal and ventral distance between the injury center to the edge of the spinal edge of the spinal cord. We now have 18 patients with up to a year follow-up, and what we've found is that perfusion has become a predictive biomarker for functional outcome in patients. The spinal perfusion index, it demonstrates strong positive correlation with Asia grade at admission. And as well, it demonstrates strong correlation between complete and incomplete injuries. I think this is a very promising technology. I think the next steps would be to look at how the spinal perfusion index correlates with long-term outcome and potentially areas of intervention to help improve perfusion so that we can improve patients' outcomes. I have to thank everyone who was involved in the lab, specifically Dr. Hofstadter, Dr. Kyng, Jonah Harmon, Jeff Hyde, and everyone else who was involved in all of the preliminary work and all of the translation. Obviously, I have to thank Dr. Ellenbogen and Dr. Ogeman, who was the PI at the time that I won the R25. With that, I'm happy to take any questions.
Great.
Thank you so much for question here. So thanks so much for presenting those data. I think the important part here is really one thing is right now it's more, we don't have it's not a predictive biomarker yet, since it correlates with severity at admission. So I think that's an important part to pay attention to that. And the second cool thing about this marker is that patients that improve actually have hyperemia in the injury center. And in our animal models, hyperemia seems to be somewhat protective of neural tissue, which is contrary to the hyperperfusion injury that we are taught. And that seems to be the, the common sort of like, like taught sort of theory of this. So there's really some new findings that we're having right now. So it's really exciting. And you see that in your graph. So patients that recover have an index above 1.
Yeah, I want to just highlight that to Dr. Hofstadter's point. Looking at the top 2 lines here, injury center versus cranial control and injury center versus caudal control, patients who improved had a perfusion index greater than 1 versus patients who did not improve who had an index less than 1, meaning that, like Dr. Hofstadter said, they're hyperemic versus oligemic.
Great. Thank you for that. It's, again, great work and great discussion. So with that, I would like to introduce our last speaker, and I'm astounded and also impressed that we are on time, if not actually a minute early. And so that's just a testament to the presenters really keeping their presentations very focused, which I think is a skill in and of itself and not one to be minimized. So our last talk for today is Dr. Tina Zhao, who's another one of our superstar interns. She's going to be presenting her talk, Extracernal Approach for Vestibular Schwannoma Resection, Surgical Techniques and Outcomes in 149 Patients. Take it away, Dr. Zhao.
Hi, my name is Tina. I'm one of the interns. Today I'll be presenting a project titled Extracisternal Approach for Resection of Vestibular Schwannoma in a retrospective group of 149 patients. And this is a project mentored by Dr. Jacob Ruzovic, and I'll be presenting some of the early results of our work here. So some backgrounds of the project. Vestibular schwannoma are benign tumors that arise from Schwann cells of the superior and inferior vestibular nerves. The goal of microsurgical resection of vestibular schwannoma are first maximal safe resection of the tumor, but then also preservation of the facial nerve. And the third objective is, when able, the preservation of the hearing of patients. Classic microsurgical technique of vestibular schwannoma resection involves first tumor debulking and then identification of the root entry zone of the 7th cranial nerve, followed by skeletonize the tumor from the 7th nerve from the cisternal component into the IAC component. And this during this portion usually involves direct visualization of the 7th nerve. What our approach differs is during the after the debulking of the tumor, we emphasize the identification and preservation of a arachnoid layer between the perineurium and the tumor tissue, without necessarily direct visualization of the 7th nerve during the surgery. And in addition to this, we also incorporated intraoperative electrophysiological monitoring of the 7th nerve to ensure the continuity and also help us to guide the course of the nerve. So if the 7th nerve is splayed due to a large tumor, maintaining the arachnoid plane provides additional layer of protection for the 7th nerve. And on the bottom, there's a cartoon illustrating the layers of arachnoid and perineurium in vestibular schwannoma. On the left, the blue layer represents the normal arachnoid layer. However, on the right, with the presence of the tumor, the purple ones over here of the 7th and the cochlear nerve, there are 2 layers of perineurium, and that's really the plane that we want to establish and also protect during the resection. This is just another published case series where they use a similar technique, and especially in just figure B here, the tumor is right here and the arachnoid layer is over here with the facial nerve over here. So instead of necessarily dissecting through the facial nerve, we want to keep the arachnoid layer intact. Going to the methods of our project, we did a retrospective cohort study of patients undergoing retrosig craniotomy for resection between July of 2010 and March of 2023 at the University of Washington Medical Center. We reviewed their demographics, clinic presentation, radiographic characteristics, audiogram if that was available, intraoperative data, extended resection, their clinical exam, especially House-Brackmann. We look at their clinical outcomes of House-Brackmann scale immediately post-operatively and also at 1 year follow-up, as well as intraoperative stimulation thresholds, audiologic outcomes, and tumor recurrence rates. We excluded those patients undergoing middle fossa, posterior petrosal, or translab approaches for resection. So some of the results, the demographics, 149 patients were included in the study. Mean age is 54 years old, which is really similar to vestibular schwannoma literature. 50% of our patients are female, and there are 11 patients with an F2 in our cohort. We're still in the process of complete analysis of the radiographic characteristics. For surgical outcomes, most of the patients were able to achieve a gross total resection that included 80% of all patients, and then the rest of the 20% got a subtotal resection. For facial nerve outcome, the y-axis represents a House-Brackmann grade, and the x-axis is a month of the timing on their treatment. So P represents the pre-operative data. Most of our patients presented with intact facial nerve when they presented. For pre-op evaluation, there are 2 that presented with a House-Brackmann of 2 and 2 patients with House-Brackmann of 3. And both of those patients were able to maintain their House-Brackmann grade after surgery. 0 on the x-axis represents immediately post-op. And again, majority of patients have a House-Brackmann of 1, and that's the mean of all of the results immediately post-op. There was 1 patient who had a House-Brackmann of 6 post-operatively, and 5 patients with House-Brackmann of 5. And as time goes on, for 6 months and 12 months post-operatively, the majority of patients still stayed with a good facial nerve outcome of House-Brackmann of 1 or 0. And the 1 patient who post-operatively had a House-Brackmann of 6 actually improved to a grade 3 at 1 year follow-up. And more than 50% of all patients who had a House-Brackmann of 3 or greater were able to improve to a 1 or 2 at 1 year follow-up. This is just further classifying the facial nerve preservation by the extent of resection, and 92% of all patients who were able to get a gross total resection had a good facial nerve outcome at 1 year with House-Brackmann of 1 or 2, and slightly less for subtotal resection. But overall, 88% of all patients at 1 year were able to have relatively good facial nerve preservation. So going to the hearing outcomes, most of our patients presented with intact hearing preoperatively, and 23 presented with non-serviceable hearing, where non-serviceable hearing is defined as pure tone average of less than 50 decibels and word recognition of greater than 50%. 36 patients who had serviceable hearing preoperatively had deterioration of their hearing. This is the audiogram results of 69 patients who were able to obtain that before and after surgery. On the graph on the left, the x-axis represents a word recognition score, and the y-axis is the pure tone average. So serviceable hearing or good hearing is represented by the top left quadrant here, where most of our patients are represented. For post-resection audiogram, towards the right of the x-axis represents worse hearing, and towards the bottom of the y-axis represents worse hearing. And most of our patients actually had worse hearing after surgery, and that is expected because it is not one of the primary goals of a resection, as facial nerve preservation is one of the more important goals here. So in conclusion, we wanted to introduce the surgical technique of extracisternal approach for vestibular schwannoma resection, with emphasis on the arachnoid plane between the perineurium and the tumor to protect the facial nerve. And 88% of all of our patients have a good facial nerve function at 1 year postoperatively. And those who had impaired facial nerve immediately post-op, most of them are able to recover at 1 year follow-up. And gross total resection may be associated with higher rate of facial nerve preservation. Finally, some of the next steps for this project. We are in the process of completing the radiology review to determine characteristics which may influence the extent of resection and facial nerve outcomes, which mostly we're focusing on the tumor size currently. And another thing that we are trying to complete is the analysis of intraoperative stimulation threshold and its association with immediate and long-term facial nerve outcomes. Most of our patients are able to have a threshold of 0.05 milliamps, but there are a few that required higher threshold. And finally, we also aim to compare the facial nerve outcomes between the NF2 and the non-NF2 cases. Here are the references, and I can take questions.
Thank you, Dr. Zhao. And I also want to thank everybody for spending the time. We still have 52 participants at this late hour, and I think that's a testament to the faculty interest in resident research. So any questions for Dr. Zhao about her interesting work?
Just a quick question from here, from Christoph. How did you guys define that the subarachnoid plane was not violated during the surgery? Is there any? Did you look through all reports, or how was that defined? That sort of like surgical technique.
That's a great question. I think in most cases, like intraoperatively, there are two perineurium layers that are able to identify, but I think we probably should look at the op report to make sure that those weren't violated in the surgery. But that's a good point.
Any other questions? Okay, I think with that, I just want to thank everybody for their interest. I want to thank the resident participants for the really obvious hard work. I want to give a big thank you to Megan, our residency coordinator, for just an excellent organization. There's a lot going on behind the scenes to make this sort of thing work that we don't all see. And so I just want to really point out just how excellent a job she did. And even during the talks, making sure that, I know the status and stay on time. It's just really unsung heroes, clearly. So thank you, Megan, for all your hard work. And Dr. Ellenbogen, if you'd like to have the last word.
Thank you, Mike Levitt. That's the last word. I appreciate you hosting and moderating this. Just wonderful.